is Dr. Sozdar Abed. I am a minimally invasive GYN surgery at Cleveland Clinic, Abu Dhabi. Here with me, I have Dr. Stephanie Ricci. She's a gynecologic oncologist, and we are going to talk about genetic screening for ovarian cancer. You see patients who referred to you for management of ovarian cancer, which is one of the GYN cancers. And how do you counsel patients who are coming with a diagnosis or with a family history of ovarian cancer about screening, genetic testing, and approaching ovarian cancer cases?
I think that it's very frustrating for women and for myself as a practicing gynecologic oncologist that there really is no screening test for ovarian cancer. They've looked at multiple modalities, a blood test called CA-125. They've looked at serial pelvic ultrasounds. In the UK, they spent a lot of money and many years looking at different screening modalities and combining different screening modalities. And everything they've come up with has not been successful in decreasing the mortality from ovarian cancer. And it hasn't decreased the late detection of ovarian cancer. Most women who present with ovarian cancer present at a late stage 3 or stage 4, that's when it becomes symptomatic, right? That's when there's so much disease in the abdomen that women start to feel bloated, and they notice that their stomach, their abdomen is increasing in size because there's fluid in there. They have pain. And unfortunately, those symptoms really only come about at a later stage. So backing up and knowing if you're at risk for this disease is essential to a woman's health and her journey. And part of that, as you said, is knowing your family history. And then based on your family history, or if someone in your family was tested, had undergone genetic testing, then you can have a test called a BRCA test, which looks for BRCA1 or BRCA2. And that would help you do certain things to reduce your risk of ovarian cancer.
Yes, yes. I agree. It's very frustrating not to have screening, and women do ask, can you do an ultrasound for me because I want to check my ovaries?
Yeah.
And I do discuss with patients, doesn't matter, even if we do ultrasound, ovaries look normal. It's not going to prevent ovarian cancer. So we educate patients about symptoms of ovarian cancer and what to look for, the bloating, the weight loss, appetite loss, changes in
Yes.
their bowel movements. And I do tell them it is similar to colon cancer symptoms, actually, just to watch for it. For patients who are at higher risk, who have a family history or certain ethnic groups, we do refer for genetic testing. So who are the candidates to really, or eligible to have the genetic screening?
So for women who have ovarian cancer, there's a certain kind called epithelial ovarian cancer, which is the most common of the ovarian cancers. And all those women should be tested, should have genetic testing for the BRCA mutation. The second group is women who have family history of ovarian cancer in a primary relative. So if your mom or your sister has ovarian cancer, or if you have a significant family history, like you have 2 or more relatives with ovarian cancer, then those women can also consider undergoing testing. The difficulty is, and all these women are referred to a genetic counselor who, will take a full pedigree, go through all the family history and determine what cancers, are there in both men and women and which genes they should be tested for. The challenge is that when you are doing a genetic test, the best person to test is the person affected by cancer, right? Because if you get tested and it's negative, but you have this family history of ovarian cancer, well, the people who developed the ovarian cancer, you don't know if they were positive or negative. So you testing negative doesn't mean a whole lot. It only means something if you test positive. So if you test positive for a BRCA mutation, then that's something actionable that we can do something about. And as you mentioned, there are also certain groups, people of Ashkenazi Jewish descent, women who have French Canadian descent. Those are kind of the major groups that we know of so far that should get tested for these mutations.
Yes, yes. And that, does bring the importance of woman visits when they come for
Exactly.
just general checkup. We do review the family history because it's not just the mom, the dad, and it's not just the woman. I think there is a misconception that no cancers, because they only look at the gynecologic cancers, which is the
Correct.
ovary, the
Correct.
uterus, the cervix, which is not genetic,
Right.
but also breast cancer, pancreatic cancer, male breast cancer. So reviewing the entire family history on both sides, the mom and the dad, it's really important to see who is eligible for the testing.
Absolutely.
And I agree, sometimes you do not have that person who developed the cancer to test.
Correct.
So then we do end up testing the patients. Patient who's testing positive, and BRCA1 and BRCA2 are more common. There's a bigger panel of the genetic disorders associated with breast, ovarian, uterine, and colon
Correct.
cancer. However, those are the most common ones. And when a patient is referred to you with positive BRCA1, BRCA2, the connection between that and ovarian cancer, how do you discuss?
Yes. So for women who are BRCA1 or BRCA2 positive, they are at significantly elevated risk for ovarian cancer and breast cancer. Those are the two major cancers that we know are associated with this particular genetic mutation. There are other cancers as well, and we're very lucky at Cleveland Clinic Abu Dhabi to have a physician who his expertise is patients who have high risk, who test positive for high risk genetic mutations or syndromes. And so he follows all of these patients in his high risk clinic and helps navigate their screening and increased detection journey. But for women who come to me with a BRCA mutation, there's a few things that we discuss. Number one is that their risk of ovarian cancer, which is a very rare disease in the general population, you're looking at 1% or less risk. But in women with a BRCA mutation, the risk can be up to 40%. So that's a huge increase in risk. And as we discussed, even for these patients, there's still no screening test. And part of the reason is that an ultrasound doesn't work is because we think that possibly ovarian cancer may actually start in the fallopian tube and not in the ovary. So if you do an ultrasound and you see normal ovaries, or you see an ovarian cyst, which is very normal to see, especially in a menstruating woman, none of these are indicators of cancer. And the fallopian tube is very thin structure, and so when you have slightly abnormal cells within it, you can't detect that on an image, right?
Yes,
Not an
yes.
ultrasound or a CT scan or an MRI. It doesn't matter. So for these women, the guidelines that we have recommend that at a certain age, usually by the age of 40 for women with BRCA1, that we remove their ovaries and their fallopian tubes. There's a discussion that I have with my patients about timing of this surgery, because some women elect to do this earlier once they've completed their family, and some women want to wait because they haven't had a family and they're unsure about whether or not they want to have one. For BRCA2, you can actually wait up to the age of 45 to remove the fallopian tubes and the ovaries. But obviously, this is a discussion that you have to have with your doctor about what the correct timing is for you. And sometimes, if there is a family member who's had ovarian cancer, you can use their age at diagnosis to determine when the appropriate time might be for you to have that surgery. The surgery is a minimally invasive surgery,
Yes.
so luckily it's not a long and invasive procedure. But obviously side effects are surgical menopause, which in very young women is difficult to undergo.
Yes, yes. Um, I agree with the ultrasound. Those women are a really significant risk, going from 1% in general population risk of ovarian cancer to up to 45% for BRCA1 and BRCA2. So surgical, which it's called risk reducing, to reduce those patient risks. Patients are still at small risk for developing cancer, which is similar to the fallopian tube cells and ovarian cancer cells, but it's the lining actually that
Yeah.
lines up the pelvis and the abdomen. Those patients do continue to follow up. Uh, do you do screening for those patients after the surgery?
There isn't really much screening to be done, um, other than, doing a pelvic exam and making sure that all of their well women, items are taken care of. Um, definitely have a lower threshold for these patients if they do have symptoms to get imaging. Um, because they, as you said, they are at about their increased risk of primary peritoneal cancer is about 5%. So, which is another very rare disease. So, obviously the threshold to get a CT scan if they have, any pain or symptoms is
Yes.
lower.
I do counsel my patients who are not ready to have surgery. If they have not completed their family, they have not made a decision to go through the surgery, dealing with early surgical menopause, that there are some methods. There is limited options to actually modify that risk.
Yeah.
One of them is birth control pills.
Yes.
Studies have showed that taking those for 5 years does decrease risk of developing ovarian cancer. So those patients, I offer that to them. Definitely come for their annual GYN visit. There is limited rule, and it's only for limited time to do ultrasound and the tumor markers, which is the CA-125 and few other newer markers, to screen those patients until they go through the surgery.
Yeah. Yeah. I think that one of the important things to know that for these women is that even though the surgery puts them into surgical menopause, that there is not a contraindication if they don't have a history of breast cancer um, to get hormone replacement after the surgery. So that's another discussion that I have with my patients about um, after the surgery, what our plan is going to be for hormone replacement. Um, Obviously, you have to take into account their breast cancer risk, and there's a lot of murky data around hormone replacement. But it looks as though more newer studies are emerging that estradiol based only hormone replacement is probably safe and maybe even slightly protective for breast cancer. So we discuss things like putting a Mirena IUD in the uterus at the time of risk reducing surgery so that they can have estradiol only hormone replacement after surgery, or taking, if they want to take oral medication. So there's a whole discussion, to be had for these patients about hormone replacement and how to do it in a safe way that will be conducive to their lifestyle.
Ovarian cancer is a rare gynecologic cancer, and the risk in the general population is 1%. What percentage of ovarian cancer is genetic?
So the genetic component we think is around 10 to 11%. Those are sort of the more recent studies that have come out that are due to BRCA. Those numbers might change in the future because genetic testing is becoming much more prevalent. And now, especially since the guidelines changed probably about almost 10 years ago now, to test every woman with epithelial ovarian cancer for the BRCA mutation, we might see a higher rate in newer studies of women with BRCA associated ovarian cancer.
So the genetic testing for those patients who either have epithelial type ovarian cancer or the one who comes based on their family history and they qualify for genetic testing or
Yeah.
screening, and they do test positive. We did discuss the screening for those women and then the surgical risk reducing for ovarian cancer and tubal cancer and primary peritoneal cancer. For some patients, patients do ask, do I have to remove my uterus? And that's higher risk in patients with the BRCA1 type,
Correct.
um, because some do have, they're attached to the uterus
Yeah.
and they want to keep it. So those are assessed a little differently than the BRCA2
Correct.
patients.
Correct. So I have this discussion with all of my patients because some women with either BRCA1 or BRCA2 um, want everything out. And I respect that decision. They're at a high risk for very, uh, you know, lethal and hard to treat cancer. So if they tell me that they really want their uterus out at the same time, then as long as they understand the risks, it actually doesn't add a whole lot more surgery to removing, the ovaries and the fallopian tubes because it can still be done laparoscopically. It doesn't change the incisions or the number of incisions. Um, but it is a little bit more surgery. And so they need to know that. And there are increased risks with removing the uterus. Um, but yes, for BRCA1 patients, I do counsel them that there is, we think, a higher risk of what's called uterine serous carcinoma, which is a very aggressive form of uterine cancer. Again, very rare, but very aggressive form that we think is conferred by the BRCA1 mutation. And so I discussed that with them as well. The third piece is um, uh, women who want to discuss hormone replacement therapy. So it's very easy. Like I said, I can place a Mirena IUD at the time of surgery so that they can have estradiol replacement therapy after. But we also discuss the fact that if we do remove the uterus at the time of risk reducing surgery, then they don't need any progesterone to
Yes.
protect their uterus. They can
Yes.
have an estradiol only regimen with a patch or a pill, whatever they want. And that we know is the safest option for hormone replacement at this time for this particular population of women.
Yes. Patients do ask, putting them on birth control pills, for an example, until they are ready to have their ovaries and
Yeah,
tubes removed,
yeah,
plus or minus the uterus. They do ask, well, what about the risk of breast cancer? And that has been, there are studies showing increased risk, studies showing not
correct.
really, does not increase the risk. So
Yeah,
the way as a general GYN, I do counsel my patients that the breast cancer risk is discussed with the breast cancer or breast surgeon
yes,
specialist. With the ovarian cancer, we know that taking the birth control does decrease the risk
yes,
of ovarian cancer. The patients who have now been diagnosed with epithelial cancer and they test positive for BRCA1
yeah.
or BRCA2, is there any additional, does that change their management compared to patients who do not test positive for
Yeah, so it
BRCA1?
actually it doesn't change their initial management. The management is still a combination of surgery and chemotherapy. So it doesn't change that initial piece, but it does change their maintenance treatment. So
Yes.
after they finish their surgery and their chemotherapy, there is we have a special medication that targets the mistake that the BRCA gene uh, makes, if you will. And there's a medication called a PARP inhibitor. I won't go into too much detail about it, but basically that targets the specific defect in women who have the BRCA mutation. And so they're placed on this oral medication for 2 years, at least 2 years following their initial treatment.
Great. So, who should be tested for ovarian cancer? Just to conclude, the discussion. Who are the patients should be referred by their primary care, by their GYN for genetic testing?
Yes, so I think that any women with a family history of ovarian cancer as it's a very rare disease, they should be referred, and they should be at least their entire family pedigree should be taken by a genetic counselor and looked into. Yes, women with family histories of breast and ovarian cancer, women with family histories of colon and endometrial cancer, because that's something called, is separate from BRCA, but something called Lynch syndrome, which also puts you at slight increased risk of ovarian cancer. Women who are either French Canadian or Ashkenazi Jewish descent. And then obviously women who have been diagnosed with epithelial ovarian cancer. Those are kind of the populations of women who should be sent to a genetic counselor and most likely tested.
Yes. Now, Lynch syndrome, yes, is another topic, and it's very interesting because women, even though it's more linked to colon, but women actually do present with endometrial cancer at
Correct.
young age more than presenting actually with colon
Yes.
cancer.
Yes.
So maybe that's another topic we
Yes,
can
absolutely. It's
discuss
another discussion, but
later.
women with Lynch syndrome are at least a 10 to 15% increased risk of ovarian cancer as well, depending on
Yes.
which mutation they have. So,
Yes, yes. Preventative measures, I think we did discuss patients who are high risk, tested positive for BRCA. What are the preventative measures that we have to
yeah.
decrease the risk?
So, as you said, they can take OCPs. We know that at least 5 years of use is associated with a decreased risk in ovarian cancer. Um, and then there are things like, if a woman's had a tubal ligation or
Yes,
her fallopian tubes removed, we know that decreases her risk of ovarian cancer. Um, but then, obviously any cancer risk reduction discussion wouldn't be complete without discussing lifestyle. And so
yes.
it's something that's simple and easy to talk about, but very difficult to implement. And a healthy lifestyle, we know, absolutely decreases your risk of many diseases, and cancer is one of them. So things like, eating a healthy diet, lots of fruits and vegetables, getting a lot of movement in your lifestyle. For women, the data and the evidence coming out looking at resistance training is spectacular, especially women in the age population that's at risk for ovarian cancer, which is the perimenopausal to menopausal age range. Resistance training is being shown to increase women's overall health in incredible ways. And then obviously knowing your family history. So being informed about the diseases that your parents, your grandparents, your aunts, your uncles, your great grandparents had will help you take a proactive role in your own health journey.
And I do want to add, seeing the gynecology. I
Oh
mean,
yes, sorry, I should
no,
say that. Yes,
the well
seeing the
women visit,
gynecologist once a year.
gynecology or
Yes,
GYN oncology or,
yes,
just in the obstetric and gynecology field,
absolutely.
once a year is a very important visit to get screened and talk about breast cancer,
Yeah.
GYN cancers. I link them all: breast,
Yes.
ovarian, uterine, tubal, definitely, because studies is showing more evidence that ovarian cancer starts in the tube or in the peritoneum, which is the lining of the
Yeah.
pelvis and the abdomen, as well as colon cancer, because that is connected to some of these GYN, the ovarian
Absolutely.
and the uterine cancer. So seeing the GYN, going over, the screening tools we have for some of those cancers, what to watch for, what symptoms to watch for and follow up, and discussing the family history. I think that all can start at the primary care and the GYN office.
Yeah, absolutely.
Thank you so much.
Thank you so much
That
for
was
having me
great.
today.
Thank you.